Good morning and welcome to the breakout session for the 2022 Nebraska Conference on Health Equity. My name is Erica Akers and I am a Public Health Equity Fellow within the Office of Health Disparities and Health Equity in the Public Health Division of DHHS. I am pleased to introduce our session speakers, Ben Tiensvold and Stefanie Olson. Ben is the Community Outreach Coordinator for the Community Health Worker Collaborative of South Dakota, and Stefanie is the Community Health Worker Section Director for the Kansas Department of Health and Environment. Our speakers will be presenting Developing and Strengthening a Sustainable Community Health Worker Workforce, Successes and Lessons Learned. After the presentation, we will end with a Q&A session. During the presentation and after, please use your chat box to input any questions or comments you may have. We'll have the presenters address them at the end. Speakers, we're looking forward to your presentation and we're ready whenever you are.
Perfect. Thank you so much. And thank you everyone for joining us today through Zoom for this presentation. I am Ben Tiensvold. I'm the Community Outreach Coordinator for the Community Health Worker Collaborative of South Dakota. And I'm joined by Stefanie Olson from Kansas. We were able to really connect and share ideas with each other, share successes, share lessons learned, as we're two states that both neighbor Nebraska. And so we've spent a couple, probably 4 or 5 hours at this point on Zoom meetings, just connecting, learning about each other's states. And there's just so much information to share. So we're so excited to share more information about our successes and lessons learned as we're working to both develop sustainable CHW workforces in South Dakota and in Kansas. So I will go ahead and jump right in here and just share a quick further introduction here and allow Stefanie to say a quick word here too, if she'd like as well. But Stefanie is from the Kansas Department of Health and Environment, the Bureau of Health Promotion, and she is the Community Health Worker Section Director. And I am Ben Tiensvold again, and I am with the South Dakota Department of Health Office of Disease Prevention and Health Promotion, specifically the Community Health Worker Collaborative of South Dakota, which is an extension of the South Dakota Department of Health. And I'll give Stefanie a chance to say a quick intro hello here as well from Kansas.
Yes, well, thanks, Ben, and thank you all for taking time to join us. I think one thing Ben and I have recognized as we've prepared this is that both of our programs are relatively new and kind of in the pilot testing and learning phase. So during the Q&A session, we're eager to hear some of your stories as well. So please collect questions, and we'll be eager to have some dialogue at the end.
I'm so excited. I am at the conference center for our first annual CHW conference that starts this afternoon, and Stefanie is able to join us for the full conference tomorrow. So I'm excited to meet her in person as well, and she'll be road tripping through Nebraska later today. So with that, we wanted to both share that both of our states, Kansas and South Dakota, both recognize the American Public Health Association's definition of a community health worker. And that definition is that a community health worker is a frontline public health worker who's a trusted member of and or has an unusually close understanding of the community served. And this trusting relationship enables the worker to serve as a liaison or a link or an intermediary between health and or social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. So we just wanted to share that both of our states recognize this definition and use this definition for our community health worker programs. And now I will turn it over to Stefanie to share a quick overview of comparing and contrasting Kansas and Nebraska.
Thanks, Ben. Yeah, so I actually grew up in Nebraska, so know a little bit about that state, and Ben has collected some of the statistics for Kansas and Nebraska. While Kansas is a little more populous than Nebraska, some of the similarities between Nebraska and Kansas and population distribution, Kansas, the bulk of the population is really centered in an eastern, right on the border population center in Kansas City, Johnson County, and then the Wichita area is kind of in south central Kansas. So like Nebraska, the population is really skewed towards or concentrated in those urban areas. And then like Nebraska, we also have a lot of rural frontier counties. That whole western border with Colorado is pretty much frontier, with just a few population centers, and the big population centers out west are like 12,000 people. So pretty sparsely populated in the west. Unlike Nebraska and South Dakota, we don't have as many tribes and tribal partnerships. So that'll be a little different as Ben goes through some of their strategies. So I'll turn it over to you, Ben.
Thank you. So now I wanted to quickly share a quick overview of South Dakota in comparison to Nebraska. South Dakota has a much smaller population than Nebraska. I was surprised, and it took me back to my elementary school geography years to realize how close in size South Dakota and Nebraska are as far as land area. But we do have just a few large population centers. We have Sioux Falls, South Dakota, which is on the far east side of the state, almost to Iowa, almost to Minnesota. That has about 250,000 in population there. And then we have Rapid City, South Dakota, which that metro area has about 150,000. And that's far over on the western side of the state, almost to Wyoming. That's where all of the touristy aspects of South Dakota are: the Badlands National Park, Mount Rushmore, Crazy Horse, etc. And we have 9 tribes here in South Dakota compared to the 6 in Nebraska. So we wanted to just take a quick moment to really show the similarities and differences between the 3 states before we jumped into our lessons learned and successes.
Right. So I'm going to start with just an overview of the history of CHW programs in Kansas, and certainly the efforts that had begun before 2021 were really accentuated with some grant funding that I think Nebraska also shares with the Health Disparities Grant, CDC Grant 2103. And then Kansas was also the recipient of the CHW Workforce Enhancement Grant 2109. So really has dramatic impact in CHW in Kansas. But next slide, please, Ben. Oh, sorry.
I so apologize. I pulled up the
That's
wrong
okay.
presentation here. So give me
That's
one
okay.
second and
That's
I'll have
okay.
the right one pulled up. I was so excited. I got it all pulled up. And
while Ben's doing that, I'll just start with a brief history. So CHW work really in a coordinated fashion began in Kansas around 2012. And the first CHW coalitions and organized CHW efforts were really concentrated in that large urban area around Kansas City. So I don't know how much you know about the Kansas City, Kansas kind of makeup, but Kansas City is divided between part of the city is on the Kansas side and part is on the Missouri side. So that's posed some great opportunities for the CHW programs because there are efforts working in Missouri that have helped our programs along, but that split has also made it a little more difficult because we have a lot of CHWs that travel back and forth between those two borders, or between the two states, which means some of the CHWs are working with 2 different regulatory systems and things like that. But around 2012 is when the CHW collaborative in the Kansas City area started. In 2016, that group expanded to a statewide coalition structure. And as the Kansas CHW Coalition was founded, Kansas Department of Health and Environment from 2016 on has really supported the mission of the coalition. So before the funding of 2013, or 2021, so last summer, that funding for the statewide coalition came from the chronic disease prevention programs at KDHE. And 2016 marked not only the founding of the state coalition, but also that was the first year that a symposium was held. So from 2016 on, the mission of both Kansas Department of Health and Environment and the coalition is to build that self-sustainability for the coalition. So getting to the place where the coalition can kind of make their own rules, regulations, and really be a self-sustaining entity. So that will kind of play into part of our story. We've been trying to prop up the coalition as that self-sustaining, self-governing entity from the very beginning. And I think, as some of this funding came in, really trying to CHW mission, nothing about us without us, and really what CHWs are trying to do for their communities, their patients, at all levels of organization. So making sure that CHW voices are reflected even at the coalition, the organizational level. Between 2017 and 2018, the coalition worked to adopt a scope of work that would cover CHW practice in Kansas, and a core competency course was begun, first kind of on the Kansas City side, and then last year, Wichita State University acting as kind of agent, a organizational entity to support some of the backbone organization for the coalition, began offering the core competency course statewide as well. Even kind of from the beginning, the goal has been to get to the place where there is a unifying certification process for CHWs in Kansas. So in 2017, 2018, a task force to explore certification, what that might look like in Kansas, was begun. And then finally, last year, that task force developed a kind of panel of recommendations for state leadership. And one of the challenges or I guess we have a couple challenges towards moving into a certification process. In Kansas, if the state held that certification, we would have to get legislative approval. And in Kansas, it's really hard to get any type of these social service provisions through the legislature in any kind of timely fashion. So the coalition has been moving towards a certification process that the coalition would certify training organizations and who could complete the certification and hold a certification, with the Kansas Department of Health and Environment recognizing their certification as the entity for things like reimbursement and things like that. So in 2020, that first cohort went through the core competency with WSU, and then 2021 in June is when we had the funding expanded and we're able to really start sending more CHWs through the training. In 2022, so just this January, the coalition convened for a special session to ratify the certification. And I'm very happy to announce that April 4th, the certification went live. So now in Kansas, looking towards sustainability and how that will work, we have that first question of like, who could be reimbursed either through Medicaid or private insurance. That question is answered now. So just a huge step towards that if we can get Medicaid to recognize CHWs as a reimbursable job title and also their services, to kind of make this fully sustainable and held by the coalition. The coalition does need to finish their 501c3 status application. They can't at this time either accept funding or pay for funding. So just a brief history. And I want to go into a little bit more. So next slide, Ben. A little bit more of what 2021, June, we got this funding. I took KDHE started a whole new section to guide the work of CHWs. And I took over in August to kind of manage this. And I know this font is way too small. You'll be getting the slides, but I just wanted to, I included this just as an example. My first job was to kind of wrangle what was happening in the state with CHWs, who already had programs working, how could we better coordinate. And so while I know you can't read all of this, I wanted you to just see, like, taking on this new funding is a great opportunity, but there are so many programs already kind of moving towards work with CHWs. And one of our challenges really is to coordinate all of those efforts so that the funding is well spent and we really build up that infrastructure for future work. So lots of players in this game in Kansas. Next slide, Ben. So two of the main partners moving this work forward with the expanded funding, or the funding we got in 2021 from the Health Disparities Grant, are KDHE, which is represented on the left here. And then part of the funding from the Health Disparities Grant was dedicated for CHW work and is being guided by a KU Medical Center team, which they've adopted the acronym COPE, which is Communities Organizing to Promote Equity. So I want to just compare and contrast a little bit the two strategies for increasing engagement of CHWs in Kansas. So the KDHE team is the team that I'm leading, and what we're to do is plant CHW teams in clinics across Kansas. So our epidemiologist helped us identify 8 counties in Kansas that had either high rates of COVID, high chronic disease rates, high social vulnerability index, and or were located in rural areas. So part of the grant, we committed to spending at least 60% of our funding on rural communities. So we have this rural carve out. So we began working to engage clinic partners, and each of these teams will consist of a program director, a health navigator, a home health nurse, and then 2 CHWs. And as many of you know, the CHW, the 2103 Health Disparities Grant, is working to mitigate COVID, prevent COVID, but also those conditions that we know exacerbate COVID. So each of that 5-person team, the CHWs, in coordination with the rest of the team, will deliver a diabetes prevention program and a self-monitored blood pressure program. And then those teams will be in those 8 counties. And I think now we've identified 10 counties and kind of pivoted a little bit from the original, and I'll explain why in a moment. But those teams would coordinate with 20 CHW community-based teams that we're expanding the RADx grant model that Kansas had been using. And if the RADx funding was to increase COVID testing. So the community-based teams would be built around local health equity teams in 4 different regions, and the regions there are kind of across the top. And the health equity teams would be guided by a team leader, and that leader would help deploy and supervise teams of 3 CHWs in each of these 20 counties to provide community support for COVID outreach efforts. I think now we're moving towards seeing if we can help those teams provide chronic disease prevention, with the idea that we know one of the barriers that was exposed during COVID was there are a lot of people that don't want to have interaction with the healthcare system, don't trust the healthcare system. And so this kind of dual model where CHWs are in the healthcare system, helping connect those vulnerable patients to services, helping assure that their experience with the healthcare system is productive and their questions are answered, and they really get that warm welcome. That team would connect with the community that didn't really have that trust and wouldn't seek services within the healthcare setting. And I mean, the hope was that these two teams would then fluidly kind of match programs and direct patients to resources, both in the community, but then the community members who needed care in the healthcare setting flow back to a handoff with the CHW in one of these clinics. So that's the model we're kind of implementing now with the clinic teams and the community-based teams. Next slide, please, Ben. So as I mentioned, the clinic team, we have funding for the staff positions. We started this recruiting effort with job descriptions, both kind of the formal, what you might see on Indeed, but then we also have provided each of the clinics with some more informal, just kind of flyers, especially for the CHW position. We've been very intentional about making sure that the clinics understand that the kind of magic of the CHWs is they're from the community. Early discussions with the clinics, we had one who said like, oh, I know the perfect position. Perfect person to be a CHW. She's like, she's been on the school board and we're like, well, we want somebody from the community. They don't have to have a degree. And so really making those positions accessible to the community members that do the best job filling those positions. We've been able to provide supplies and training for all of the clinics as well. And really tried to set these clinics up for a sustainable path in the future. As I mentioned, all of the clinics will then also do some chronic disease prevention and will help with sustainability planning. Next slide, please. So we started out with this, like, we're going to get these 8 clinics, and who wouldn't want this in their team? It's great funding. Pretty much the whole team setup is covered by this grant. We provided some information on the website to reach out. We're working with a quality improvement organization to kind of help build those workflows. We built some internal documents to present to the clinic teams. And there have been some challenges we'll discuss even with all of this support and funding. Our team, next slide, please, Ben, has also prepared some infographics for the clinics that have contracted with us to start to help the clinic-wide staff understand what a CHW is and how to really integrate them into the workflow of the clinic. This model is based loosely or pretty heavily actually on what UPenn has done in the past, where the community health worker team gets referrals from clinic staff, from doctors, nurses, based on either a social determinants of health screening or a health condition screening. But and I think this is probably true in South Dakota and Nebraska as well. Though community health workers have been around for a while and is not totally a new concept, for many of the clinics we're working with, this is a totally new concept. So providing some of that education, how a community health worker is different than a social worker, or how a community health worker is different than what your nursing staff does, or even what your navigation staff does, has been one of the pieces that was really missing as we started talking with this. So we've put together some education pieces to help the clinics kind of communicate within their organizations. And then just recently, next slide, please, Ben. We have been so excited to be at the table for Medicaid discussions. So Medicaid in Kansas had some ARPA funding to do some pilot work with CHWs, and reached out to KDHE, both the Bureau of Health Promotion and the Bureau of Family Health, with some ideas of how to guide those pilot projects. And we were like, very quick in saying, like, we can do this today. Give us the money and we will get these teams set up right now. So we looked at what New Mexico had done several years before with trying to do a per member per month model. And I think some of what we've tried to do with Medicaid is, what can we do without having a state plan amendment, which would require the legislature to get involved. So we're looking at expanding 5 of our original sites with this funding, collecting more data to really be part of, in Kansas, the MCOs are contracted on a 5-year basis. And so we're up for that reprocurement. This year or next year. The legislature wants to delay it, I think, in hopes that a new governor will be elected. So we're at the table, which is just huge, and having discussions with Medicaid about how CHWs can increase social determinants of health screenings, and looking at what programs these teams are already doing, like the diabetes prevention, the Healthy Heart Ambassador program, that can reduce cost. So really proving our return on investment and value add for the Medicaid program, but also looking at some of our most vulnerable populations and where our data gaps exist. Kansas, and I assuming Nebraska and South Dakota are similar, our maternal health rates are not good for BIPOC populations. And so seeing how we can use some of these CHW programs to bridge those gaps. And mental health, behavioral health is also a area of concern in Kansas. So how can CHWs kind of fill in those gaps? Next slide, please. I just wanted to, so with all of this, the map on the left shows where CHWs were working in Kansas before 2021 and the increased funding, and 2022 shows or the map on the right shows where we expected CHWs to be after these big expansion efforts. And even this map on the right, I'm looking at one of the counties I did a site visit to yesterday is not highlighted yet. So the workforce is just expanding exponentially. And so we're trying very hard to be strategic in how we build in education pieces to support recertification, and how we can help the coalition be in a position where they can be self-sustaining, and this work continues after this grant funding is over, which we know we have through August of 2024. We have some funding with a couple new grant opportunities on the horizon, but really making sure that this work will remain after this initial funding. And I think that is my introduction to what we've been doing. So some challenges. It's been a real challenge to coordinate some of these efforts. Just that long list of like what everybody's doing everywhere, but even within the grant, those 2 missions, the KU team moved much quicker than the KDHE team did, and by the time we started talking with some of the clinics that we assumed would be our partners, they had already contracted with the KU team, and we're like, wait, you're not supposed to be in the clinics. We're supposed to be in the clinics. So that coordination has been a little tricky. We've had the new partnerships with the clinics have been fantastic, but a challenge with this, when we started approaching clinics in September, we're like, oh, this is going to be easy. Who wouldn't want $400,000 a year to really put in place this program, but hiring has been so difficult, even within our own team at the state. I started posting for positions in August, and finally we have program managers, full staff as of March 21st. So, hiring has been a real challenge everywhere. Beginning a new program, even though we're like, this is going to help you, and this is going to, take some of the burden off of your staff that's just overwhelmed. Getting that started in the middle of overwhelm and COVID and Omicron has been really, really tricky. I feel like we had meetings in January with like programs that were really excited and yes, we want to do this. And then we couldn't talk to them until mid-February because they were just overwhelmed. So internally, we have a really slow contracting process. So even when we're like, yes, we have the budget, we're ready to send this through, sometimes it's taken up to 1.5 to 2 months to get the contract through so the clinic can actually get started. And back to the kind of coordinating, even, figuring out how to collect this data amongst, now we have 10 clinics using different EHR systems and different screening tools, and some aren't using screening tools, and then Medicaid and external partners, like what screening tools are they using? So that's all been a challenge. I will say we have had some successes. Next slide, please, Ben. Partnerships. I mean, this is where your success is. I was just doing a site visit with one of our partners in Colby, and I think we met with them 7 times before they said yes. So, just a lot of education. And I mean, it really is true that trust moves at the speed of partnerships, or partnerships moves at the speed of trust. And you can't really force that or accelerate that. And I mean, that's been, I think a lot of Ben and I have compared how many sleepless nights we've had, because it's like, we want to do this well. We want to be that trusted partner. And we have 2 years. In the beginning, it was 2 years to get these huge projects up and running, get the clinics like staffed and moving to the place where they can even begin collecting data, and kind of builds that infrastructure that will lead this to be sustainable. Ben and I started sleeping a tiny bit better when they extended it to 3 years, but that partnership and building those partners is where all of our success has come from. Without those clinic partnerships, and it's been just a lot of Zoom meetings and site visits now too, like presenting and helping understand, and even internal partners helping understand what the benefits of this program are. That internal team building has been a real success, and getting some of those programs that already existed to really align all of our efforts, and certainly having Medicaid at the table now and being part of that long-term discussion hopefully will lead to sustainability. And you all know this, the real success is those stories the CHWs are telling, the people who are now getting medication because they are working with a CHW, and the people who are, on healthier path and connected to resources. So a lot of challenges and a lot of work, but the successes are really worth it. So, and with that, I'll turn it over to you, Ben.
Thank you. And I owe you a coffee or something for pulling up the wrong slides. That's my biggest fear in presenting. Well, I'll pull up the wrong slides, and I did it.
Yeah, so. I'll be seeing you tomorrow. So
yes, send me your order. So I was going to pay attention and not take notes and just soak in all of Stefanie's presentation. And I still found myself taking a whole page of notes. So thank you so much. There's so much to learn as we continue through this journey. So I wanted to share a brief overview of what we're focused on here in South Dakota. Some of what we're working on is very similar to Kansas, and some is different, but each state knows their own state the best. And so it's really up to each individual state to really identify what works best. So quick timeline for us here in South Dakota. We didn't really get started with community health workers until 2015. In 2015, our Department of Health conducted an environmental scan of all 50 states to see where each state was at when it came to CHWs. And then we also did 45 key stakeholder and key organization interviews across South Dakota to see if CHWs were of interest. So we do have 9 tribes within South Dakota. All 9 tribes have had CHR programs or community health representative programs since the late 1950s, early 1960s. But outside of our tribal programs, there weren't really any community health worker positions out there. And so overwhelmingly, the responses that we received from key stakeholders and key organizations was that this sounds like a great idea. We should definitely move forward. There's a lot of hurdles to work through, but this is definitely needed within our state. So in 2016, as Stefanie mentioned about partnerships and the importance of partnerships, we partnered our Department of Health and our Department of Social Services, who oversees our South Dakota Medicaid, together, and we hosted a work group with key stakeholders and key organizations to really develop key recommendations for CHWs in South Dakota. The Department of Social Services and South Dakota Medicaid under Department of Social Services then took those key recommendations, and from 2016 through 2019, they did all of the work behind the scenes so that as of April 1st, 2019, through a state plan amendment to our South Dakota Medicaid state plan, CHW services are reimbursable. And although services are reimbursable, that doesn't mean that there's an organization presenting or promoting or encouraging CHWs and CHW development. And so in January of 2020, the Community Health Worker Collaborative of South Dakota launched through the South Dakota Department of Health to really focus on developing that awareness and workforce development across the state. So obviously we all know how 2020 and even 2021 turned out, but we were able to get a lot of foundational work done to really develop out the organization. We wrapped up 2020 and early 2021 with developing a strategic plan for the Community Health Worker Collaborative. And then in 2021, we learned of the health disparities funding that became available to South Dakota as well to all of the 50 states. And that's really allowed us to launch what we call request for applications to fund CHW program development. So similar to what Stefanie is doing in Kansas, we have funding available for individual sites and organizations to start a CHW program in hopes that it will become a sustainable CHW program. So that's worked out really well here in South Dakota to really get this funding where it needs to go to get these positions developed. So we were able back in 2016 to have our Department of Health and our Department of Social Services, who oversee South Dakota Medicaid, come to an agreement on what should be the South Dakota scope of work for community health workers. And this partnership with developing the scope of work is super helpful as we promote and develop the workforce here in South Dakota. Now, obviously, there's other things that community health workers do that are not listed in this scope of work, but overall, when it comes to any form of reimbursement, this is the scope of work that Department of Social Services through South Dakota Medicaid reimburses for. So the 3 areas are health system navigation and resource coordination, health promotion and coaching, and health education, specifically to teach or promote methods and measures that have been proven effective in avoiding illness and or lessening its effects. So having the scope of work that is used by both Department of Health and Department of Social Services has been really beneficial as we raise awareness about the workforce. So the Community Health Worker Collaborative of South Dakota launched in January of 2020 with a mission to promote, support, and sustain the community health worker profession in South Dakota. We're really envisioning a well-established statewide network of CHW professionals who provide a wide range of services for South Dakota. And we have support through being an extension of the South Dakota Department of Health Office of Disease Prevention and Health Promotion. So I think Kansas is a little bit further along than we are, but eventually I think the Community Health Worker Collaborative of South Dakota will break off from the Department of Health and transition into being an independent 501c3 organization that still works day in and day out with the Department of Health. So that's where we're at as far as the Community Health Worker Collaborative and our development. We did develop our strategic plan, which really focuses on 5 goal areas for South Dakota. And this strategic plan was especially helpful because it really guided us through the large influx of funding that came with the CDC Health Disparities Grant. We were able to take our strategic plan and really rapidly expand it to support that increase in funding and really set out a guide for us for the next couple of years. So our strategic plan focuses on 5 key areas or goal areas. These are awareness, training, workforce development, reimbursement, and then career ladder and lattice. And looking back now, one of our lessons learned would be don't use the word lattice, call it cross training, because we have to educate everyone on what lattice means as well. So those are the 5 areas of our strategic plan, and it's really been helpful in guiding us moving forward. So through our CDC Health Disparities Grant, we have multiple partners that we funded to really assist us in moving this workforce forward and developing the workforce here in South Dakota. So in South Dakota, we have 3 health systems, 2 on the eastern side of the state and 1 on the western side. So a health system in South Dakota is a group of hospitals, clinics, etc. And so we really just have 3 health systems. So we were able to fund all 3 health systems. And then we provided a CHW program manager within each of those health systems to then develop out CHWs at individual sites across their health systems. So all 3 health systems within this first year have really gotten a lot of awareness and information shared across their health system and are to the point of now having a couple I don't want to say pilot programs because we want them to continue and be sustainable and not be a pilot, but some initial programs that are really starting and have hired individuals and trained them as CHWs. We also funded all of our federally qualified healthcare centers, and we also included funding for the Community Healthcare Association of the Dakotas, who has a full-time staff member through this funding to oversee the CHW development at all of the FQHCs. We were able to then provide some additional funding for our training programs to make sure that they could support the training needs as we continue to develop CHWs across the state. We were able to provide some funding as well to our evidence-based training programs, such as the National Diabetes Prevention Program, as well as Better Choices, Better Health SD, which is our Stanford Model Chronic Disease program here in South Dakota. And then Delta Dental of South Dakota Foundation is working to really pilot and identify how CHWs and cross-trained CHWs can work within the dental communities. And then we also are working with our statewide helpline center to be a resource for our CHWs. So they are actually training a couple of their team members to be community health workers so that a community health worker can reach out to them as they're working in the field and work together to identify resources and really focus in on that first area of the scope of work, the patient navigation resource coordination piece. We're also working with CHW Solutions out of Minnesota to help us approach our private insurers or private payers here in South Dakota. Megan and Megan are the 2 leaders of the CHW Solutions work, and they've been a huge asset to our team here in South Dakota, as Minnesota Blue Cross Blue Shield is the first health plan to cover CHW services for all of their members. So we were really fortunate to be able to partner with CHW Solutions. And as this is a CDC grant, we're very careful that we're informative and not persuasive as we reach out to our health plans, but we want to share all of this great information with them as well. And then we were also able to partner with the South Dakota Foundation for Medical Care, and they provided 2 contracted staff members whose full-time positions for the next few years are tribal outreach liaisons to really connect in with all of those established CHR programs across South Dakota. So starting in just an hour and a half here, we have all of our tribal CHR programs meeting for a pre-conference to really learn more about what they do, what supports they need, and how we can assist and really recognize the great work that they do, and also be that supporting organization as they continue to grow and develop, and also have access to our funding that's available to strengthen their programs as well. So we do have the South Dakota Community Health Worker Planning and Assessment Toolkit. This is a really great opportunity for organizations looking to develop a CHW program to go through this toolkit and learn more. It's a 4-module toolkit. There are 2 versions of the 4-module toolkit. There's the self-guided version, which you can jump in, jump out as needed. And then there's the CEU version, where you need to go through start to finish to receive those free CEUs. So please take a look at that if you're interested. It's South Dakota specific, but Nebraska being a neighbor just south of South Dakota, I think many things would apply for Nebraskans as well as you go through this toolkit. And if you are looking to go through it and receive those free CEUs, just double check first with your organization to make sure, you know, if you're with the, for example, Nebraska social work organization, make sure that a CEU offered in South Dakota would apply before you're going after those CEUs. But certainly a free opportunity to go through and take a look at. And we just launched in the past month our community-based toolkit. And this is really important for our community-based organizations here in South Dakota who aren't looking to develop CHW programs within a medical or clinical setting. So the Community Health Worker Planning and Assessment Toolkit is really focused on medical clinical integration, and then our community-based toolkit is really focused on community integration. So looking at training, we do have certificate training programs here in South Dakota. So it's about 400 hours of training offered online through a community or technical college. We also were able to grandparent in the Indian Health Service Community Health Representative Training Program. This is especially important as we continue to work with our CHR programs across South Dakota. And we really want to recognize all of the great work that they do. And I have a sticker that says I'm a CHW ally for our conference, but we have stickers that say I am a CHR, and we're really wanting to recognize and share the great work that they do, especially when it comes to those stories. I was actually out in Pine Ridge, which is the Oglala Sioux Reservation, on Monday, and we spent the day meeting with their CHR program there, and they prepared, and I've got to pull it out of my backpack and show it because I'm so proud of it. They prepared a whole booklet for us that is all just impact statements and success stories. And so we read through some of them in our meeting, and I'm so excited that they shared all of those with us because that really goes so far to spread the message about community health workers and the work that community health representatives do. Then we also have our evidence-based training programs, as I mentioned as well. Those training programs are more specified training programs that fall under the 3rd area of the scope of work, the health education. And so there we have Better Choices, Better Health SD, which is our chronic disease self-management program. And then we also have National Diabetes Prevention Program as well. So just a little bit more information about our workforce development. As I mentioned, we have the request for applications available. We have 300 awards earmarked to fund the development of CHW programs across our state. So far, we've awarded 27 of the 300 awards. We're awarding approximately $50,000 per fiscal year to fund the development of the program as far as awareness of the profession, training, so hiring, and then also training or cross-training of an individual to become a community health worker. And then also looking at workforce and organizational development. So we do have a state plan amendment that allows for Medicaid reimbursement as a fee-for-service reimbursement for CHWs. And so we really want to provide organizations the opportunity to set up their billing, set up their electronic health record integration, things like that, so that they can really use this funding as almost startup funding to get to the point of a sustainable program. So we're really excited to start working with funded sites across South Dakota. I didn't even think of making a map to show off the counties, but I'm going to do that now and steal that idea from Stefanie, because when we take a look at our 66 counties in South Dakota between our CHR programs and where we have CHW programs just starting, I think we'll see a really great progression throughout the years of where CHWs and CHRs are located. Jumping into reimbursement, want to share first a warning that I know just enough to explain it. But we also have a really close working relationship with our South Dakota Medicaid team. We have a policy strategy manager, and her entire job is to provide technical assistance and support regarding the CHW reimbursement. So she and I text each other all the time. We call each other all the time. Everyone in our state knows she's the one to go to with those questions. Medicaid is really excited and supportive of CHWs, and so that's been a great partnership. So I'll be sure to put her email address in the chat at the end too, in case you have any really specific Medicaid questions about the state plan amendment. But overall, I'm comfortable enough to explain it a little bit here. We have a Medicaid state plan amendment, which is a fee-for-service reimbursement. It does require a qualifying condition and or a qualifying barrier. So what that means is a patient to qualify for receiving CHW services that would be reimbursed, they need to have a qualifying condition, which is looking at all chronic diseases, as well as substance use disorder, tobacco use, high-risk pregnancy, obesity, prediabetes, etc. There's a very lengthy list of qualifying conditions. And outside of qualifying conditions, an individual could also receive CHW services for reimbursement due to qualifying barriers. So qualifying barriers are geographic distance to health services, which we're South Dakota, we're very rural, but also looking at individuals who might not have a phone to make appointments or might not know how to make appointments. So instead they're going to the emergency room or acute care versus going to their primary care provider. And then also looking at language and communication barriers as well. We know not only for those who don't speak English, that's a huge barrier, but also just the complex medical terminology that providers and other healthcare team members often use. Having that CHW there to jump in and say, this is really confusing and we don't all have medical degrees here. Let's explain it in a way that we can really understand it and that the patient can benefit from this visit. So the patient does need a qualifying condition and or qualifying barrier. I don't like math, so I'm not going to dive deep into all of the reimbursements. I'm just going to share that very simply put, 1 hour of services is reimbursed at $41.78 for that hour. There are also group reimbursement rates as well. So for example, if you're leading a Better Choices, Better Health group workshop or a national diabetes prevention program training, those are offered at reimbursable rates that are for a group setting as well. So those come out to, for a group of 8, $116 per hour. The CHW services must be provider ordered. So there just needs to be a referral and a brief care plan included from a provider. And then individual CHWs must be employed and supervised by an enrolled CHW agency. So what that means is that there's just a couple policies and procedures that an organization needs to submit to South Dakota Medicaid before they can seek reimbursement for those services. So we do have a full billing and policy manual that's located on our website, or a link to it from our website, and that gets updated often. I'm noticing here as I'm presenting that I have the screenshot of our manual from last March. So it's actually been updated this March of 2022. So I need to replace that with a new screenshot, but it does get updated every few months, and it's up to about 13 pages now and really includes a lot of great information. So looking at career ladder and lattice or cross training, we're really transitioning now to not only continue to develop awareness and develop the workforce across South Dakota, but also look at how we as the Community Health Worker Collaborative can provide that association type support for the community health workers and for the community health representatives within South Dakota. So we're really excited to start launching a bi-weekly huddle where 2 times a week, anyone who's a CHW or CHR can jump on, and it's a peer-to-peer support opportunity to really share ideas, thoughts, concerns. Oftentimes community health workers have to deal with a lot of tough situations when working with their patients and clients. So especially in a small state like South Dakota, where we have 1 or 2 CHWs at different organizations, we want them to have that opportunity to have that peer-to-peer support across the state. We're also looking at monthly networking and educational calls for our CHWs, and we're just in the very infant stages of starting a certification process as well. We're also looking at those professional development opportunities for community health workers. whether they want to train in an additional evidence-based training program, if they want to do more disease-specific focused trainings, things like that. And then also looking to the future and mapping this out for sustainability. You know, we might have someone who starts today as a community health worker, but maybe 10 years down the road, they can grow into a manager position and be managing a team of community health workers. So we're really looking at that as well, and looking at the CHW as a profession and not just a stepping stone to other places. So we do have a career comparisons page on our website as well, and this has been super helpful and really showing how CHWs compare and contrast to other positions like nurses, like social workers, CNAs. I think we're up to 12 different professions, and we have it laid out so you can click on each one and view, here's what a nurse does, here's what a CHW does, and here's how they work together. So that's been really helpful in showing some of those positions, especially for a small state like South Dakota, that could enter into that cross-training aspect, for example, a dental assistant in CHW. But it also really shows how there's positions that are very different from CHWs, and really the CHW is there to complement those positions, not take away those positions. So thank you all for joining us today. It was great to share information about what we're doing in the neighboring states above and below Nebraska. We'd love to have you reach out to us further. We're always excited to connect, and we're so close. I'm sure we can even make arrangements to meet in person if that were something we'd be looking at, or if it's a shadowing opportunity or just jumping on a Zoom call. We're happy to help and connect in any way we can. I always learn so much when I connect with other states, as we're just so new to all of this CHW work. And really, I think we're all in it together as far as wanting this workforce to succeed. And so it's great to make those connections and connect with everyone. So here's our contact information. Feel free to reach out.